ultrasound or point-of-care medical examination or ultrasound-assisted physical examination is also examination of the heart with an ultrasound device. But there are some fundamental differences because of the different device and technique used. Basically, the standard echocardiogram use a full function, larger ultrasound machine that has more function and allow a full assessment of the cardiovascular system. And because it has more function, and not just 2D exam or color Doppler exam, it also has other imaging modalities such as three-dimensional exam and other more complicated technology. It allows a more complete assessment of the cardiovascular system, and it requires more training, and therefore it's mainly performed by trained cardiologists, and it's usually performed in the echo lab. The topic of today, however, is not a complete standard echocardiogram. It's a focused exam using usually a highly portable handheld device that allow you to perform a focus exam at the bedside, not a complete exam, but a goal-directed focus exam of the heart at the bedside, sort of like a more advanced stethoscope. Now, the stethoscope is an diagnostic instrument that has been used for more than 200 years. And it's a device to detect the heart sound transmitted from the heart. And with technological advancements, we have digital stethoscope where the heart sounds can be recorded digitally. More recently, in the past 2 decades, we have this handheld ultrasound device that we can use a ultrasound transducer to perform an ultrasound examination of the heart at the bedside. So there are now different types of handheld ultrasound machines produced by different vendor, but the concept is the same. It's a pocket-like device, pocket-sized device that you can carry around like a stethoscope, and can perform bedside examination of the cardiovascular system using a ultrasound transducer, and the screen of the device is very small. It's incomplete, but it allows a pretty good visualization of the 2D image of the cardiovascular system of the heart. Now, we'll talk about the essential technique to use this ultrasound device to examine the heart. And there are, just like a stethoscope, you have to put your stethoscope using a bell or diaphragm, and at the designated area on the precordium. There are some standard maneuver and technique that you need to use or memorize using a stethoscope. Same in using a POCUS or handheld ultrasound device. There are some echo views that are standard views that will teach you to use in the examination of the system. And first of this view is called parasternal long axis view. The patient has to lie left laterally, similar to the maneuver that when you're using the bell to listen at the apex for a mitral stenosis. You ask the patient to lie left laterally, and the transducer is placed on the in the second or third intercostal space at the left sternal border. So it's called a parasternal view, and it is a long axis view because the imaging plane of the ultrasound is cutting the heart in its long axis. So here you see a transition is positioned in the third or fourth intercostal space, and this is the long axis view. On this view, you can see several structures. Here is the left ventricle. You can see that this is the interventricular septum. This is the left ventricular posterior wall. And connected to the left ventricle is the left atrium. And you have the aortic valve here, opening and closed, mitral valve here, opening and closed. This is the root of the aorta. And this is the right ventricle at the anterior aspect of the screen. So this is the location of the transducer probe, and the transducer image is usually like a fan-like sector because we're using a transducer that generates ultrasound in a sector. If you rotate the transducer clockwise 90 degrees, then you change from the parasternal long axis view to the parasternal short axis view. So the imaging plane is cutting the heart in its cross section, in its short axis. And what you see here is the left ventricle now, because it's cut in its cross section, so it's a circular in shape like a donut. And here on the anterior and right side of the left ventricle is the right ventricle. And you can see is that from this cut plane, the right ventricle is shaped like a crescent. It is not like a round structure, because it is a triangular shaped structure, and in this structure, in this section, it looks like a crescent. And here is the left ventricle. In the middle part, you can see also the papillary muscles cutting in this cross section. These are the papillary muscles here. Now, switching to another window, the patient is still lying left laterally with one of his arm held up like this to spray out the ribs, and therefore allowing you to use the intercostal space as an acoustic window near the apex of the heart. And the transducer is put here, and the imaging plane is cut like this. Then you will see this is the 4-chamber view. So usually there will be a light or marker here on the side of the transducer. So to obtain this view, the marker has to be pointing towards the patient's left axilla. Then you will obtain this 4-chamber view. In this 4-chamber view, you see the 4 cardiac chambers: left ventricle, left atrium on the right side of the screen, and right ventricle and right atrium on the left side of the screen. And you see the mitral valve here and the tricuspid valve. And this is the apex of the left ventricle. An interesting feature here is that the tricuspid valve attachment is not at the same level as the mitral valve attachment to the septum. So there is a slight apical displacement of the tricuspid valve. These are normal features. If there is no apical displacement, then we are suspecting a atrioventricular canal cushion developmental defect, such as a patient with a premium ASD. If you have an excessive displacement of the tricuspid valve into the right ventricle, such that the distance between the tricuspid valve and the mitral valve insertion in the septum is more than 8 millimeter per meter square of the patient's body surface area, then it is excessive, and it is called Epstein anomaly. But anyway, these are complex congenital heart disease. Don't need you to understand in detail, but just want you to notice there is a difference in the insertion point of the mitral and tricuspid valve, such that you will not confuse the right side from the left side, because the tricuspid valve is always more apically displaced than the mitral valve, and it is in the right ventricle. Now, at the same acoustic window, at the apical window, without moving the probe, you can counterclockwise rotate the transducer, such as the marker now is pointing up towards the patient's head, and you will see this two-chamber view. So basically, this two-chamber view is just a orthogonal section along the long axis of the left ventricle. So here now you see two-chamber. This is the left atrium, this is the left ventricle, and this is the mitral valve. And you are looking at the different territory of the coronary artery supply of the left ventricle in these two views. Because here in the four-chamber view, this is the anterolateral wall, this is the interventricular septum, the infraseptal segment, and here in two-chamber view on the right side here, this is the anterior wall, and here is the inferior wall of the left ventricle. So if you have the anterior myocardial infarction, you will see regional wall motion abnormality or akinesia or hypokinesia of the segments supplied by the left anterior descending artery, namely the apex, the anterolateral wall, and anterior wall. If we have an inferior MI supplied by the right coronary artery as a result of occlusion, you will see akinesia, no movement of the inferior septal wall and also the inferior wall here. So looking at these two views, you can also help you to identify regional wall motion abnormality and the territory of infarction or ischemia in the patient with acute coronary syndrome. Now, the third window I will teach you to use in focus exam is the subcostal IVC view. So here is a patient's precordium, and this is the subcostal region below the cytosternum in the upper parts of the abdomen. And this is a surface anatomy of the right atrium and superior vena cava and inferior vena cava. So basically, in the subcostal IVC view, the transducer is placed in the right side of the upper abdomen, and the marker of the transducer, which is here, is pointing up towards the patient's head vertically. So you have a vertical imaging plane that is cutting across the long axis of the IVC. So this is what you will see on the IVC subcostal view, and this is the IVC, and this is the vein joining the IVC. This is the hepatic vein here, and this structure here, a echo-den structures is delivered, and the IVC is draining into this structure here is the right atrium. So to assess the IVC dimension and its collapsibility on respiration can help you to estimate the central venous pressure or the right atrial pressure. So you can consider it as a ultrasound counterpart of the physical examination of the jugular venous pressure. In a patient with a normal right atrial pressure, the IVC diameter on this view should be less than 2.1 centimeter, and it decrease in its dimension or collapse during brief inspiration or sniff by more than 50%. You see here, the IVC will collapse. You see here, it's collapsed. It reduced its diameter by more than 50% when the patients take a deep breath or sniff, because the sniffing reduced the intrathoracic pressure, reduce the RA pressure, and therefore the proximal parts of the IVC pressure, therefore it collapses on the inspiration. It means that the IVC pressure is normal or low. In the patients with a in the middle here is the intermediate right atrial pressure. You would see that the IVC is engorged. Its diameter is more than 2.1 centimeters. but it still collapse during sniffing. So you see here, it collapse during sniffing by more than 50%. It's either not enlarged, but sniff less than 50%, or it's enlarged, but the collapse during sniff is more than 50%. Either way, it indicates a intermediate right atrial pressure. So, but here in this example, it is a distended vein, more than 2.1 centimeters. You see the ruler, the marker here, it's 1 centimeters. It's more than 2 centimeters, but it's collapsed more than 50% during sniffing. On the right side here is a patient with heart failure, elevated central venous pressure. You see here the IVC is distended more than 2.1 centimeters if you measure the proximal part of the IVC, and it does not collapse. It basically does not change its diameter during inspiration. You can see the lever is moving down. It means that the patient is taking a breath in, descend the diaphragm. But despite the breathing, there is no change in the dimension of the IVC. So here in this example, this patient has typical heart failure, congestive heart failure. And if you do a physical examination of the neck, you're likely to detect a elevated JVP. So this is how you can use a point of care ultrasound to assess the fluid status or the central venous pressure of a patient non-invasively, and this is very useful. For example, in assessment of patient with shock, you want to distinguish between hypovolemic shock versus cardiogenic shock versus distribution shock. So if you have a hypovolemic shock, you expect that the IVC collapse and it's small in diameter. If you have a patient with cardiogenic shock, more likely the patient have a distended IVC and does not collapse. If you have a distributive shock, more likely the central venous pressure is in normal range, and you would detect a IVC that is in the intermediate range of the right atrial pressure. So this is a useful guide to assess the fluid status in the patient with hemodynamic disturbance. So these are the possible clinical scenarios that we can use UAPE to work up the patient for possible cause and sometimes even provide therapeutic intervention, as in the case of pericardiocentesis in a patient with cardiac tamponade. So in the patient with shock, we can assess the LV function, the ejection fraction, and also the volume status by the IVC. In the patient with heart failure, we can assess the LV function and also the RA pressure by the IVC. In the patient with cardiac arrest, we would like to rule out like myocardial infarction or tamponade or pulmonary embolism. In the patient with acute chest pain, we would like to assess for evidence of acute coronary syndrome. We might detect regional wall motion abnormalities, but we can also detect something that is more devastating, which is aortic dissection causing acute chest pain using POCUS. In the patient with suspected pericardial effusion or cardiac tamponade, POCUS is definitely very useful because we can assess the pericardial fluid. And if you hear a murmur, you can use POCUS to evaluate the valve and the origins of the murmur. This is the definition of heart failure. There are two types of heart failure. One is heart failure with reduced ejection fraction. One is heart failure with preserved ejection fraction. So because ejection fraction is the cornerstone in distinguishing these two types of heart failure, therefore echocardiogram or UAP is very important. Apart from echo exam, the diagnosis of heart failure has to be established with the presence of typical symptoms and signs of heart failure. In HFrEF, we also need a reduced ejection fraction of less than 40% on the echocardiogram. The diagnosis of HFpEF is requiring the symptoms and signs of heart failure, because heart failure is always a clinical diagnosis. If you don't have symptoms and signs of heart failure, you don't have congestion, you don't have shortness of breath, then you cannot call a patient's heart failure. So they have to have symptoms and signs of heart failure. But in HFpEF, the LV ejection fraction is preserved, so it's either normal or only mildly reduced, which means more than 40% ejection fraction. And it also requires assessment of the presence of cardiac structural abnormalities such as left ventricular hypertrophy, left atrial enlargement, and also diastolic dysfunction, which has to be assessed using comprehensive echo. This is because in a patient with shortness of breath, if they have COPD, for example, they will have a normal LV ejection fraction. So, but the patient have shortness of breath as a result of COPD, not heart failure. So you need something else to provide evidence that the patient does have structural heart disease. So the presence of left ventricular hypertrophy or LA enlargement. And the measurements of biomarkers, NT-proBNP or BNP, can also support the diagnosis of heart failure. Now here is an example of using UAPE or PROCUS to assess the patient's ejection fraction with heart failure. So you see in this case, the heart is enlarged and the contraction is reduced. The ejection fraction is reduced. Ejection fraction is defined as the stroke volume over the end diastolic volume. So you can see the end diastolic volume here is increased and the contraction of the heart is reduced. The ejection fraction in this case is 25%. And you can see here, there is a severe left atrial enlargement and right atrial enlargement, and also some degree of right ventricular enlargement too. So with more experience, you'll be able to just give a visual impression of the ejection fraction. So this is the ejection fraction that is reduced, about 25%. On the other hand, this is a patient with a heart failure but preserved ejection fraction. You can see here on this paroxysmal long axis view, apical wall chamber view, and the paroxysmal short axis view, the left ventricle is not dilated. The contraction looks okay. If you measure it, it will be 55%. But what's abnormal here is the grossly thickened left ventricular wall. See, very thickened left ventricular wall. This patient have severe left ventricular wall thickening and also severe left atrial enlargement. And this is actually a case of HFpEF with cardiac amyloidosis. In the patient, cardiac amyloidosis is the infiltration of amyloid protein in the left ventricle, in the heart, in the cardiac wall, leading to thickening of the cardiac walls and diastolic dysfunction. And they can present with heart failure, but the ejection fraction can be preserved in the early stage. Now, let's take a look at some acute case that POCUS can help to make the diagnosis. This is a first patient. He or she is admitted to the coronary care unit for acute myocardial infarction. And on day 2, the patient developed hypotension, and there is a pansystolic murmur. So, in a patient presenting with myocardial infarction and shock, these are the differential diagnoses. The first is the myocardial rupture. Because of the recent infarction, patients can have a rupture myocardium. This is especially common in patients who present late, so they did not pass the therapeutic window for revascularization or reperfusion. So delayed presentation of myocardial infarction. Also in patients who present for the first time for myocardial infarction, more likely to have myocardial rupture. And comparing large infarction versus a small infarction is more likely to rupture. Because in a small infarction, the rest of the left ventricle will contract more vigorously, and that creates increased ventricular pressure that can cause rupture of the myocardial infarction. If you have a large infarction, the left ventricular function is reduced, and that we cannot generate the high pressure to rupture the myocardium. And it's also more common in female. So myocardial rupture can occur at different sites. If it occurs at the free wall of the left ventricle, for example, the lateral wall, then it causes perforation into the pericardium, and it creates a pseudoaneurysm. If it's ruptured the ventricular septum, it creates a shunt between the right and left ventricle, and it's called ventricular septal rupture. And the patients can also develop shock. If the rupture is in the papillary muscles, then you will have acute mitral regurgitation. And papillary muscle rupture is much more common in a patient with inferior infarct, because the inferior wall and the papillary muscles are both supplied by the right coronary artery. And the second differential diagnosis in the patient with post-MI shock is LV pump failure. If you have an extensive myocardial infarction, the LV ejection fraction is reduced, and the patients can have a shock as a result of reduced cardiac output. If you have a right ventricular infarction and failure, you can also have shock because of reduced cardiac output from the right heart. And also you can have left ventricular outflow tract obstruction after an inferior myocardial infarction, because after inferior myocardial infarction, the anterior wall will contract more vigorously in this condition, and this can cause obstruction of the left ventricular outflow tract. So these diagnoses can be very easily or readily differentiated on echocardiogram or ultrasound-assisted physics exam. So in this example, we see here is the apex of the heart in the apical four-chamber view. This is the left ventricle, this is the right ventricle, and you can see here, this part of the ventricular wall, which is the interventricular septum in the apex position, is akinetic because of the infarction. Color Doppler showing the blood flow, see there is a shunting across the ventricular septum around the apical septal infarction. So POCUS can help to establish diagnosis of myocardial rupture, and in that case, the pansystolic murmur is not due to acute MR, it's due to ventricular septal defect. And the treatment would be a intra-aortic balloon pump insertion and surgery, immediate surgery to repair the ventricular septum. Now this is the second case. Day two post myocardial infarction, and then he developed cardiac arrest. You see here, after cardiac arrest is resuscitated when the heart is beating again. You see here in the posterior wall of the left ventricle, on this parasternal long axis view, there is a filling, there is a defect here in the akinetic posterior wall, and there is a occlusion space outside the left ventricular posterior wall. You see here, there is some color Doppler signal inside this occlusion space, which is outside the left ventricle. So this is a case of a posterior free wall rupture leading to a pseudoaneurysm after myocardial infarction. And the patient can present with a sudden cardiac arrest because of the reducing cardiac output and the tamponade of the left ventricle. And this is called pseudoaneurysm because in a true aneurysm, the wall of the aneurysmal sac should consist of three layers, which is the endocardium, the intima, and the endocardium, the intimal layer, the medial layer and also the adventitial layer. So these are the layer of the vessel wall or the heart. But in the pseudoaneurysm, it's only lined by a incomplete layer, because actually the free wall has rupture, and this space here is basically the pericardial space. So you can only, this lining here is only the pericardium. There's no intermal layer, and there's no medial layer, because it's all rupture here at the site of myocardial infarction. But it looks like an aneurysm, so it's called pseudoaneurysm. Case 3, patients, day 5, post anterior myocardial infarction, then develop heart failure, and then develop transient slurring of speech. Focus examination showing this is the left ventricle, the apical four-chamber view. It's the left ventricle. You see here the apex is not contracting, and there is a mass here in the apex. This is the apical thrombus formed as a result of the apical myocardial infarction, day 5 after myocardial infarction. And this can embolize and cause cerebrovascular events. So the treatment would be anticoagulation. Case 4, 56-year-old lady, good past health, presented with acute shortness of breath and hypoxia, and also hypotension. So this is an echo exam. You see there's a short axis view, this is a long axis view. And remember, this is the left ventricle. And remember that I told you normally the left ventricle on the short axis view is round, like a donut. And the right ventricle is normally crescent shape. But in this case, you can see first, the right ventricle is severely dilated. On this view, the area of the right ventricle is even larger than the left ventricle. And it's no longer crescent shape. It's more like a rounded shape. And the LV is no longer rounded shape. It becomes a D shape, like a D, letter D. And this is because this interventricular septum is being pushed by the right ventricle towards the left ventricle, and therefore flattening the interventricular septum. And this is a sign of acute cor pulmonale, acute pulmonary hypertension as a result of pulmonary embolism. Flattening of the ventricular septum in both systole and diastole, because the pulmonary pressure, pulmonary arterial pressure, and therefore the right ventricular systolic and diastolic pressure are elevated in the patient with acute massive pulmonary embolism, and causing becomes higher than the left ventricle, and therefore causing flattening of the septums towards the left ventricle. And if you see this, you should suspect the patients with acute pulmonary embolism. However, there is always some limitation, because this sign, RV abnormalities on POCUS, is not a very sensitive nor specific signs for acute pulmonary embolism. So you can have a small PE, a submassive PE, but the right ventricle is not dilated, or you can have a right ventricle dilated as a result of other causes such as COPD or chronic idiopathic pulmonary arterial hypertension, or whatever cause of pulmonary hypertension. So it's not very sensitive nor specific, but it did help us to lead us to consider further evaluation in a patient with suspected PE for further confirmatory tests such as a CT pulmonary arteriogram. And it's very useful, can be used to in that side. And if you see this in a patient with acute shortness of breath, it's a pretty good sign to proceed to a CT to confirm the presence of pulmonary embolism. And sometimes, if the patient is too unstable to go to the CT, we may sometimes empirically treat the patient as pulmonary embolism if we detect these obvious signs on bedside echo. And we may need to give thrombolytics sometimes if a patient is really critically ill. Now, case 5 is a 64 gentleman, history of hypertension, presenting with abrupt onset of chest pain, severe and tearing in nature. And if you look at the ECG, there's no ischemic changes, and the chest X-ray shows a rotated fin. So this is the bedside exam. This is a paroxysmal long axis view, apical four-chamber view. The left ventricle size and also the ejection fraction is normal. Left atrium is not dilated. Right ventricle is normal in size. The mitral valves and the aortic valves are normal. But what is abnormal here is there is a very subtle sign of a dissection flap, or it's a thickening of the aortic wall. So this structure here is the descending thoracic aorta. This is descending thoracic aorta cross-section. So it's a round shape. And we can examine the aorta carefully using focused examination. This is the suprasternal view. I didn't teach you about this view, but with a skilled operator, we can obtain this suprasternal view. This is the aortic arch, descending thoracic aorta, aortic arch. This is a common carotid artery. And this is the descending thoracic aorta in the modified apical two-chamber view. And here in the subcostal long axis view, you can also examine the long axis of the abdominal aorta. Subcostal short axis view is the short axis of the abdominal aorta. And you can see here there is a dissection flap in the abdominal aorta. This is a dissection flap of the abdominal aorta. Dissection flap of the abdominal aorta and also of the thoracic aorta. You see here, this flickering is the flickering of the dissection flap of the abdominal aorta. Here you see the abdominal aorta. This is the dissection flap. There's a line here. This dissection flap separates the abdominal into the true lumen and the false lumen. So this is a case of acute aortic dissection. And if you can do a focus to diagnosis, it would be very nice, because the timing of aortic dissection diagnosis is always delayed. It's required high index of suspicion, and it should be confirmed on CT or MRI, usually CT. But echocardiogram, transthoracic echocardiogram is also very useful to rapidly diagnose aortic dissection. So case 6 is a A&E, 72 years old man with history of stage 4C lung, come to A&E because of dizziness. Blood pressure was on admission was lowish, and partially recovered after fluid challenge with 500 ml of normal saline infusion. This is the focus exam, and you see here this is a paroxysmal long axis view, apical four-chamber view. This is the left ventricle. It's smaller than normal, and there is the right ventricle here is severely compressed. The right ventricle is indented inwards, and there is a echolution space here and also here surrounding the heart. Here on the apical four-chamber view, you see the right ventricle is compressed. The left ventricle is also very small. You can barely see the left ventricle, and there is a large echolution space around the heart. This is pericardial effusion. This echolution space around the heart is pericardial effusion. How do I know this is not pleural effusion? Because pleural effusion is also an echolution space outside the heart. The key is to look at the location of this effusion relative to the aorta. Here is the descending thoracic aorta, and the effusion is between the aorta and the left ventricular wall. So it's in front of the aorta. This has to be pericardial effusion, because the pericardium, only the pericardial effusion can present between the aorta and the left ventricle. Pure effusion should be around the aorta, and therefore should be posterior to the aorta. So here I can be sure this is a pericardial effusion. This patient presents with hypotension, and this here is a subpostural view of the IVC. You see it's distended and does not collapse, suggesting high central venous pressure consistent with cardiac tamponade. And here in the subpostural function review, you see this is a liver and there is an echolution space, pericardial effusion, circumferentially surrounding the heart and compressing on the heart, and both the right ventricle and left ventricle are being compressed. Therefore, this patient heart cannot fill, and therefore the stroke volume, the cardiac output is markedly reduced, and therefore hypotension. So the treatment is echo-guided emergency pericardioscentesis. Pericardioscentesis means percutaneous drainage of the pericardial fluid by inserting a needle through the pericardium into the pericardium, through the precordium into the pericardial sac and drain the fluid. So what we do is that we use echocardiogram to guide the placement of the needle. When the needle is inside, we inject agitated saline. You see these whitish bubbles here are the agitated saline. These are saline bubbles. That is, after injected, it fills the pericardial space. So this helps us to make sure that the puncture needle is inside the pericardial sac rather than inside the heart. So inside the heart, you see the purple saline appearing in the heart, in the right ventricle. But now it's in the pericardial sac. And after pericardioscentesis, you see the pericardial effusion is disappear, and the pericardial chamber is returning to its normal size again, and the patient's blood pressure returns to normal. So this is the final slide. I hope that this lecture really gives you some taste about what bedside ultrasound is, and it's not difficult to learn. We have experience in teaching medical students in obtaining the 4 essential POCUS views over only a 2-week anesthesia rotation. This is a publication 3 years ago, and most students and also the tutor found it satisfying to learn this POCUS technique, and most of the students can obtain a rather satisfactory pericardial window, especially for the first 4 is the parasol long, short, and apical windows and the subcostal windows. These 4 windows are easy to learn and easy to get, and I'm sure you'll be able to learn that very quickly. And hopefully we can use it in future during your internship. Okay, so thank you very much for your kind attention. I'll take any comments and questions. So there's a question from Oscar. Would agitated saline in pericardioscentesis cause air embolism? Okay, that's a very valid question. The answer is no, for several reasons. Number one, because the agitated saline is injected into the pericardial space, not into the intracardiac space or any blood vessels during pericardioscentesis. So therefore, even there are bubbles, it will not go into the circulation and therefore will not cause air embolism. That's number one. Number two is that even sometimes we do inject agitated saline into the circulatory system. For example, when we want to use, when we want to diagnose the presence of interatrial shunting through a patent foraminal valley (PFO), we sometimes inject saline into the vein then examine with echo to see if there's any bubble crossing from the right heart to the left side, to left heart, which will indicate intracardiac shunt. But it will seldom, or it would rarely, if ever, cause air embolism, because if there is no intracardiac shunt, the air bubbles are too big. And when you do agitated saline, you're basically mixing air with a saline with two syringes. So these bubbles generally this way are too big. It's more than 10 or 15 micrometer. So it's much larger than the red blood cell actually. And it does not cross, normally it does not cross the lung. It cannot cross the pulmonary circulation. The pulmonary circulation will filter out all these bubbles because the bubbles simply is too big to cross the capillaries in the lung. So they will just eventually be absorbed into the blood, and there will be no bubbles crossing to the left side and causing an air embolism or stroke, that kind of thing. And even if it cross, for example, in the patient with atrial septal defect, some of the bubbles may cross through the left side. Again, because these bubbles are usually, the amount will not be a whole lot, only a small amount of bubbles would cross to the left side, even if there's a PFO. And also these bubbles are unstable, therefore they will soon rupture, or the air inside will soon be absorbed by the plasma. So it seldom will cause air embolism. Usually air embolism is just a result when we accidentally inject a column of air. For example, if you use a syringe to inject a column of air into the bloodstream, then that column of air is much less likely to absorb and really block blood vessels this way. But if it's bubbles, it will not usually cause air embolism. Okay, thank you. That's a good question. Is there any other questions? Okay, there is a question. I wonder how would you comment on the current situation in hospital authority for the implementation of the POCUS technique, so whether it is now currently used in the A&E or family medicine department. Okay, so the question is about what's the real-life implementation of POCUS technique in the public hospital. There is, as far as I know, no general guidelines or principles of how to or where to implement it. It's all like the doctor or the department think that they need this technique, then they will usually seek for some training from a cardiologist or from the POCUS user, and then implement it in their clinical patients. And it's commonly used actually in any department, and many town are using it, not only for heart, but in other cases, especially in trauma cases. There are some A&E emergency ultrasound protocol that they use to assess trauma patient, detecting blood in the cavity, to evaluate patient with shock. And family medicine, that's commonly use it. Some of them are using it, not very commonly. But in the department, internal medicine, general medicine department, and anesthesiologists, they are the cardiologists, colleagues that most commonly use this technique. And I think the principle here is that they are welcome to use this technique as long as they have adequate training. So if they have added training, knowing the limitation and advantage of this technique. I think this will benefit patients. But it is very important to understand focus is not to replace a standard echocardiogram. As I have mentioned at the beginning, a standard echocardiogram is a complete full examination that provides more information than the focus. But the focus can provide rapid, focused, and information that may directly immediate management. But subsequently, the patient should eventually receive a full echocardiogram if the focus detects abnormalities that require further evaluation. I hope I answered this question. Okay. So if there are no further questions, if you have further questions, feel free to email me or drop me a message. I'm very happy to answer. If there's no further question, I thank you very much for your attention, and I hope you have a great weekend.